Hello, this is Dr. Paul Sachs from Brigham and Women's Hospital and Harvard Medical School. And today I'd like to talk about two papers that have recently been published that have some direct applicability to clinical practice for care of HIV patients. The first of these is a paper by Lima et al. That was published in the Journal of AIDS, or JAIDS. And it looks at the impact of introducing a new viral load assay into the clinic. As you know, most clinics have been using the bDNA assay or the Roche ultrasensitive AmpliCore assay for the past several years. And recently, Roche has decided to update this assay using a real-time PCR called TaqMan. Now, the TaqMan PCR has many advantages and can be done more easily in clinical lab settings, and hence it's going to be very widely adopted. What the Vancouver group did was they heard from their practitioners that there was an unexpected increase in the number of patients who had low-level detectable viremia. So they investigated the incidence of low-level viremia in patients who were tested with this newer assay and compared it to a period previously when they had the Roche AmpliCore assay. What they found was that about 6% of the patients tested who previously had undetectable viral loads had now a detectable assay versus a 3% rate previously. Obviously, these low-level detectable viral loads can be tremendously anxiety-provoking for both the patient and the practitioner alike. But the real question is, what does this represent? There are some who view this as representing low-level viremia that's detectable on this assay that was not detectable previously, and hence analogous to the kind of viremia that's detectable using investigational assays. The authors thought that perhaps the TaqMan assay is more prone to false positive results. Suffice to say, we don't have the clinical implications of these low-level viral load results, but I can tell you from our own experience in our clinic, when we introduced this assay, the same thing happened. So regardless of what it means, and I suspect it's actually not going to mean very much, since a lot of the people who have this low-level viremia have been suppressed for years, but regardless of what it means, as a provider, you're going to have to take a little extra time to explain to a patient why the viral load is now detectable at this low level, typically between 100 and 400 copies, when previously it had been undetectable for years. The second paper I want to discuss is one that's just published in the Annals of Internal Medicine, and this is by Silverberg et al., and it looks at the response to lipid-lowering therapies among a group of patients with HIV and compares this to individuals who are HIV negative. It used the large Northern California Kaiser cohort for the study, so it included about 900 HIV-positive patients and about 7,000 HIV-negative patients. And what the study found, looking retrospectively at this cohort, was that patients with HIV responded less well to statin therapy, and they responded especially less unfavorably to gemfibrozol for triglycerides. So the statins didn't reduce LDL as much in HIV positives as it did in HIV negatives, and the gemfibrozol didn't reduce triglycerides as much. Another important finding from this study is that pravastatin was the least effective of the statins used. This will come as no surprise to cardiologists who already probably knew that pravastatin was the least potent of the statins that we have. But in particular, it's important for HIV-positive patients because frequently this is the statin we choose first since it has the fewest drug-drug interactions in this drug class. Another finding that was very interesting was that, especially with the triglycerides, or most notably with the triglycerides, the type of ART that the patient was receiving had an impact on the response to therapy. So if patients were receiving boosted PIs, this blunted the lipid-lowering effect of the gemfibrozol in particular. So these two papers, I think, really have practical applications to clinical practice. They're both just recently published, so at the very least, the abstracts are online now. I discussed the first of these papers, the viral load assay paper, in my blog, which is called HIV and ID Observations. I want to thank you for taking the time out to listen to these summaries.